So we'll just give folks another minute or so, and then I will do the welcome.
Wonderful, thank you.
Yeah, thanks for being here. I assume folks are starting.
I'm happy to. I was telling folks this gave me an excuse to go digging into some Massachusetts specific contraceptive access numbers, and as a native masshole, so to speak, I was excited to be able to take a deeper look at my own home state.
We will be very interested to see what you came up with. Students and I were talking a little bit about sort of the connection from last week and thinking about family planning and a little bit of reading we did. And so very interested to see what you have to say. So I think we're ready. I'll do a little welcome here and then I will turn it over to you, Rachel. Sound good?
Sounds great. Thank you.
Great. All right, so hello everyone. Welcome to tonight's Green Living Seminar virtual presentation. I'm Elena Traister. I am a professor at the Massachusetts College of Liberal Arts in the Environmental Studies Department. This semester's Green Living Seminar is organized around the theme Individual Actions and Environmental Sustainability. All of these webinars are free and open to the public. They take place on Wednesdays at 5:30, and you can register online at www.mcla.edu/greenliving, all one word. You can also find podcasts there of previous presentations. You can find videos of this semester's presentation on our YouTube channel as well. I'll link to from that site. Today's presentation will be probably about 40 minutes or so. It'll be followed by a Q&A session. The Q&A box will remain open. You're welcome to put questions there anytime you have them, and we'll address them at the end. And just a quick announcement about next week's presentation, which we hope you'll also join us on Wednesday, February 10th. We'll be hearing from Dr. Ralph Buehler, Professor and Chair of Urban Affairs and Planning at Virginia Polytechnic Institute and State University. He'll be giving a talk titled Cycling for Sustainable Cities. Today's presentation on preventing unplanned pregnancy will be given by Rachel Fay, Senior Director of Public Policy at Power to Decide. This second talk in our series follows last week's presentation, in which we heard from Dr. Seth Wines that the single action people can currently take to most effectively reduce their contribution to climate change is to choose to have one fewer child. When we consider this finding alongside the statistic that more than half of pregnancies among women younger than 30 are reported to be unintended, it seems there's a clear opportunity to support individual empowerment, social well-being, and environmental sustainability all at the same time. And so we're so happy to have today Rachel Fay with us. I'm going to turn it over to you, Rachel. Thanks so much.
Thank you so much, Elena. And I really appreciate getting the chance to speak to you guys. And I was telling Elena as we were getting started, particularly happy to be talking to a crowd from my home state of Massachusetts. So shout out to all of you guys. Elena, if you could advance to the next slide, please. So, we're going to talk a little bit about preventing unplanned pregnancy, and what I want to do as we talk about this is talk about sort of how this connects to sustainability, but also how that history has some fraught consequences in the past. Talk about what unplanned pregnancy looks like right now in the United States, what we can do in terms of both federal and state policy, and then what individuals can do in their own capacity to be advocates for making sure that everybody has access to high quality family planning. So that's the general plan. Elena, if you can give me the next slide. So Power to Decide is a nonprofit. We work to ensure that all young people have the power to decide if, when, and under what circumstances to get pregnant and have a child, no matter who they are, where they live, and what kind of economic circumstances they might face. If you can go to the next slide, please. So to do that, Power to Decide approaches this from a sort of three-legged stool. People need the information in order to make decisions that will help them achieve their goals for their family. They need access to care, particularly birth control, but preconception care for when they want to have healthy pregnancies, et cetera. And they need to have a sense of opportunity that these things are really open to them and that it is worth it to them within society to act upon these goals. That yellow circle of opportunity is really the X factor, but also the hardest one to get at. Some of the work that Power to Decide does around that has a lot to do with making sure that the information we provide is resonant to the audiences we are hoping to reach and who depend on us for information. We spend a lot of time talking about the role of parents and adult mentors and champions in young people's lives, and a lot of other things, including work with entertainment media to try and distill messages about planning and spacing pregnancies in order to achieve your own personal goals. So that last piece I know is harder to grasp, but really, really important if you think about the cocktail of what it takes to get to better unplanned pregnancy numbers when it comes to the United States. Next slide, please. So I want to talk a little bit about reproductive coercion. And I don't know how much the previous speaker addressed this, but I think as you guys probably know from your studies, you know, the 1960s and 70s were really a time where folks were concerned with population growth. The book, The Population Bomb, was widely read. A lot of the support that we saw for programs like the publicly funded Title X Family Planning Program, a lot of that bipartisan support came from concerns about reproductive population growth. So, but I want to be clear, it's not just a history when it comes to environmentalism and reproductive coercion. There's examples as recently as last year in ICE detention centers where a nurse whistleblower disclosed that several women were being subjected to hysterectomies without their knowledge or consent. There are a lot of other system level examples of reproductive coercion, including forced sterilization in the US for low-income Black women, many of whom were sterilized for much of the 20th century in what Fannie Lou Hamer called the Mississippi appendectomy, or to immigrant women in the 1960s and 70s who were sterilized without their knowledge in California. And if you haven't, I really encourage you to see a documentary called No Mas Bebés, which you can find on PBS that talks about this in greater depth. So I will also say that Power to Decide, which often serves as a resource for policymakers at the state and federal level, in the last 10 years, we've been approached by a policymaker who wanted to put forth a bill that would pay women on Medicaid additional money if they got an IUD. We explained why that was a terrible idea. We did not move forward with that, and we talked that policymaker out of doing something on it. But the reason I bring all this up is when we talk about family planning, we are talking about individuals for their own families. Someone might have a goal for 3 or 4 children, and it's our job in the reproductive health space to make sure that they have the ability to parent those children, to have those pregnancies with health and with bodily autonomy. So when we talk about family planning in an environmental sustainability concept or context, we are really talking about helping everyone to achieve their own personal goals for their family size, for what they hope to achieve, for birth spacing, but all determined at the individual level. Next slide, please. So when I talk about unplanned pregnancy, let's just set the stage for what we're looking at right now in the United States. So I know Elena gave you a number for pregnancies under 30, where it's over half. 45% of all pregnancies across all ages in the US are unplanned. And when we talk about unplanned, what we mean is that when women themselves were asked about that pregnancy, they either wanted to become pregnant later or did not want to become pregnant. So it's a combination of mistimed and unwanted. Unplanned pregnancy is increasingly concentrated among low-income women. So the rate of unintended pregnancy among women with incomes of less than 100% of the federal poverty level was 112 per 1,000, which is more than 5 times the rates of women with an income of at least 200% of the federal poverty level. Because of systemic racism in our country, Women of color, particularly Black and brown women, are more likely than white women to have lower incomes and depend on publicly funded programs, particularly the Medicaid program and the Title X Family Planning Program for their contraceptive care. Next slide, please. So at the same time, what we know is that birth control is wildly popular in the United States. So first of all, let me just say that 99% of American women, of all American women who've ever had sex, have used a method of contraception. Now, some of those methods can be abstinence, but spending a good chunk of their reproductive years seeking to not become pregnant is a common experience for almost all sexually active women in the United States. 8 in 10 adults in the US agree that birth control is a basic part of women's healthcare. And here I think is a really important thing to stress. 91% of Democrats, but 66% of Republicans. If you look regionally, you'll also see that there isn't greater agreement. In fact, Massachusetts in the Northeast is in the 78% agreement, whereas in the South, you'll see 81%. So again, there is not regional differences when it comes to support for birth control. And the reason I think this is important is because we have seen in my time just at Power to Decide in the last 10 years, 3 cases in front of the Supreme Court just on contraceptive coverage as required by the ACA. We have seen numerous attacks by the previous administration and conservative lawmakers on birth control programs and other mechanisms for getting people access to the full range of birth control methods. So it's important to remember that the only place that this battle is being fought is inside state legislatures and inside the Beltway. Outside of those places, there is not a lot of mixed opinion about the value of birth control or its place in women's health care. Next slide, please. So I want to talk a little about what programs women who depend on publicly funded family planning, I should say people who depend on publicly funded family planning, turn to. So for those of you that aren't familiar with Medicaid or deeply familiar with Medicaid, Medicaid pays for roughly 3/4 of all publicly funded family planning care. So it is the biggest payer when it comes to publicly supported family planning. Whether you qualify for Medicaid is greatly dependent on the state that you live in. In 38 states, including Massachusetts and the District of Columbia, Medicaid has been expanded as allowed by the Affordable Care Act to cover anyone making at or below 138% of the federal poverty level. Above that, you then qualify for subsidies on the Affordable Care Act exchanges. However, in 12 states that have not expanded Medicaid, it's often very difficult to qualify even if your income is below the poverty level. In those 12 states, the median income limit for parents to qualify for Medicaid is just 41% of the poverty level, or an annual income of $8,905 or less for a family of 3. And nearly all of those 12 states, childless adults remain ineligible for Medicaid. In 26 states, some of whom are those 12 that don't cover Medicaid, or did not expand Medicaid. In 26 states, there's expanded Medicaid coverage just for family planning services, up to the level where a person would be eligible if they were to become pregnant. So this is really important. If you think about it from a state perspective, what they're saying is, if we have to cover you when you're pregnant, we would also like to give you coverage in order to decide when you become pregnant, because from a state perspective, it's a cost saver. But it's also a great way to help a lot of low-income people have access to a basic part of their care. The issue we have seen in recent years with this policy is states, led by Texas, seeking to exclude any clinic that also offers abortion care or is affiliated with a clinic that offers abortion care from participating. So what this means is, if you are in Texas right now, you might have Medicaid coverage of just family planning care, but you can no longer seek that care at many of the clinics throughout Texas, which leaves you with limited options for where you can go with that Medicaid card, essentially forcing you to say, have your face pressed up against the glass. You know, I'd love to have family planning care. I have this card that covers me, but I don't have access. So that comes down to the next program that I want to talk about. So if Medicaid is focused on coverage, the Title X Family Planning Program is focused on access. For 50 years, the Title X Family Planning Program has provided federal funding to a network of health centers around the country that provide free or low-cost birth control and related services to millions of people annually who have low incomes. In August 2019, the Trump administration undermined the ability of the Title X program to continue to provide quality care by enforcing what we call the domestic gag rule. The rule forced health centers receiving Title X funding to make an impossible choice. Either they stop providing information about where people can access abortion care and keep the Title X funding, or keep providing complete information and referrals for abortion care, but lose a critical source of funding to provide contraceptive care to their patients. And I should note that no Title X funding covers abortion care right now. So this was about what information they could share. They were already not using these dollars for anything abortion care related. As a result, more than 1,000 clinics left the Title X program without other clinics in those areas to replace them. The number of patients served by the Title X program went down to 1% between 2018 and 2019. And I should say that in 2019, the policy was only in effect for 5 months out of the year. And we still saw a 21% decline in patients served. 6 states, Hawaii, Maine, Oregon, Utah, Vermont, and Washington, lost all Title X funding. So it was, you know, an unmitigated disaster for publicly funded family planning and their support networks. What it really meant for people going to those clinics was the clinic might still have their doors open, but they might no longer be able to provide a broad range of birth control methods because they didn't have the funding that supported being able to stock those methods. That might mean multiple trips to the clinic. It might mean shorter hours or fewer providers, meaning longer waits for an appointment. And as I often like to say in my advocacy, you can get very pregnant waiting 30 days or more. So we were really pleased, Power to Decide was really pleased last week when President Biden issued a presidential memorandum directing HHS to begin the process of rescinding the domestic gag rule. But that process is going to take time. And as I said, the damage has already been done by a policy that's going to be with us for some time. Next slide, please. So now I want to turn from publicly funded family planning to contraceptive coverage as it's addressed in the Affordable Care Act. So prior to the Affordable Care Act's preventive services provision going into effect, women spent on average 30 to 44% of their total out-of-pocket health costs just on birth control. In 2010, when the Affordable Care Act became law, it included a provision requiring women's preventive services to be covered at no additional out-of-pocket costs. This is, think about like copays and deductibles, any sort of additional payment that you make beyond your premium. HHS then commissioned a study to determine what were the high value services that should be included in this no copay coverage. Contraception was among the services they identified, and that's why to this day, contraception is a service that's required to be provided without copays. From the beginning, the Obama administration exempted religious houses of worship from the requirement to cover contraception in their plans and created what we call the accommodation for religiously affiliated nonprofits. Think, for example, of a Catholic university or Catholic-owned health system. In the accommodation, the religiously affiliated nonprofits would not cover the cost of contraception in their insurance plans, but their insurers would directly cover that cost so that employees still had coverage. Fast forward to the infamous Hobby Lobby Supreme Court case. Hobby Lobby sued as a for-profit company and said, we object to covering some methods of contraception and we don't believe we have to do that. The court sided with Hobby Lobby and said that essentially as a closely held family-owned company, not a company traded on the stock exchange, not a company with a board of directors or a non-family board of directors, that this court sided with Hobby Lobby and said essentially that the Obama administration was going to have to do something to exempt them. So the Obama administration expanded the accommodation to include some for-profit companies that objected, provided they were closely owned by one family. So that's where we were for a few years until nonprofit religiously affiliated organizations also sued, claiming that even the act of stating that they won't cover contraception triggers the accommodation, and their employees then have contraceptive coverage, and therefore that violates their religious beliefs. In this case, often referred to as Zubik, we never fully got a settled ruling from the Supreme Court. They sort of kicked it back down to the lower courts to try and have the plaintiff and the government work out a compromise. And that's where things were before President Trump took office. When President Trump took office, he issued a set of regulations that broadly exempted any employer or university, for-profit, nonprofit, that objects to any method of contraception or all methods of contraception for any religious or moral reason. Next slide, please. So I like to think of this as a loophole so large you could drive a Mack truck through it. We don't actually know at this minute how many employers are availing themselves of this new exemption to the contraceptive coverage requirement. It will take some time to hear from employees trying to figure out why their coverage is not going through before we in the advocacy world can get our arms around this. But a group of state attorneys general led by the Attorney General of Pennsylvania did sue the Trump administration about this past summer. And the case went to the Supreme Court. In Trump v. Pennsylvania, the Supreme Court upheld the rules that these broad exemptions from employers. However, I like to say if there's a good way to lose, we lost the good way. So the court did not consider whether the contraceptive coverage provision violated any religious rights of these employers. It just considered whether the Trump administration had the executive authority to make those rules in the first place, and concluded that it did. This is important because it means that the Biden administration also has the authority to make different rules when it comes to contraceptive coverage. President Biden did commit during the campaign to restore the Affordable Care Act's contraceptive coverage mandate that was in place before the US Supreme Court's Hobby Lobby decision. So we're looking forward to working with the new administration on this. Contraception is basic health care. Almost all women in the US use it, as I said, but the Supreme Court ruling really allows employers to single it out. And for now, across the country, women have to worry about whether the health insurance they're already paying for with their premiums is going to cover this most essential part of their care. Next slide, please. So not to make a bad situation that much worse, but to also acknowledge that we are living in, I hate the word unprecedented, so I'm just going to say extraordinary times. And we are seeing the impact that COVID is having on family planning decision-making, goals, and access. Right now, we have some preliminary data that is backed up by actually a study I think I just saw, I want to say it was in CNN the other day, but not surprisingly, maybe it was the Wall Street Journal, not surprisingly, women are putting on hold their childbearing right now. I think there was a lot of talk in the early days that there'd be some sort of pandemic baby boom, but it turns out that staying home with the children you already have while working from home and parenting, full-time 100% of the time is not conducive for folks wanting more children. So more than 40% of women have reported that because of COVID-19 pandemic, they changed their plans about when to have children or how many children to have. 1/3 of women wanted to get pregnant later or wanted fewer children because of the pandemic. Black women, 44%, and Hispanic women, 48%, were more likely than white women, 28%, to state that because of the pandemic, they wanted to have children later or wanted fewer children. And I should note this corresponds with the fact that the economic impacts and healthcare impacts of the pandemic are disproportionately being felt by Black and brown women. Lower income women, 37%, were more likely than higher income women, 32%, to report this change. In terms of contraceptive use, 1/3, 34% of women agreed with the statement, because of the COVID-19 pandemic, I am more careful than I used to be about using contraception every time I have sex. 23% of women reported thinking more about getting a long-acting contraceptive method like an IUD, the implant, or an injectable shot because of the pandemic. However, it also impacts access to contraception. About 1/4, 28% of women said they worry more than they used to about being able to get the sexual and reproductive health care they need because of the COVID-19 pandemic. In addition, 27% of women reported that because of the pandemic, they worry that the ability they used to have to afford and obtain contraceptive method may not be the same. 1 in 3 women reported that because of the pandemic, they had had to delay or cancel visiting a healthcare provider for sexual or reproductive health care, or had trouble getting their birth control. Such barriers to timely care were more common among Black and Hispanic women than among white women, and more common among queer women than among straight women. Low-income women were also more likely than higher-income women to report having experienced delays in being able to get contraception or sexual and reproductive health care because of the pandemic. Into this void, we have seen, I think, not just in the family planning space, but in the healthcare space generally, a huge uptick in the use of telemedicine. Among women using the pill, 24% had reported that because of the pandemic, they had switched to a telemedicine appointment with their healthcare provider to have their prescription filled. But again, here's where the inequity comes in. We are looking at a system in which there is a significant portion of low-income Americans and Americans living in rural areas that don't have consistent broadband access, that don't have the devices and the knowledge and the information they need to use telehealth services. So while this is a partial solution, it doesn't work for all methods. And right now, it's perpetuating some of the same inequities when we look at who has access and who does not. Next slide, please. So who does have access and who does not? Sorry, I just see a chat here. I want to make sure I'm, okay, sorry, just checking in to make sure I'm good. So when we look at who has access and who is not, this is a map of the United States looking at county level access to clinics offering the full range of contraceptive methods. Just for you data wonks out there, when we say full range of contraceptive methods, we use being able to offer the IUD and the implant as a proxy for all methods, because typically those are the methods that are hardest for clinics to stock and offer. So right now, more than 19 million women in need of publicly funded family planning, and we define that as women under 250% of the federal poverty level, or less than $30,000 a year for an individual, live in contraceptive deserts, counties where they lack reasonable access to a clinic that offers the full range of contraceptive methods. The way to find reasonable access means that there's at least one health center or provider for every 1,000 women in need of publicly funded contraception. Of that 19 million, 1.5 million live in counties without a single clinic that offers the full range of birth control methods. This means they may live near a clinic that offers all methods, but the clinic has to serve such a number of people that the wait for an appointment is really long. It may also mean that someone lives near a clinic that used to offer the full range of methods, but can't afford to do so after losing Title X funding. So birth control access in the United States is not all it should be, is the key takeaway. And I think that's important when we have that number of how many pregnancies are unplanned in the United States. Next slide, please. So I want to dive into this data a little and talk about the Commonwealth of Massachusetts. So it doesn't look that bad, right? Everything is purple at least. And if you look at Berkshire County, where Massachusetts College of Liberal Arts is located, it looks not so bad, right? But in the state of Massachusetts writ large, you have 365,000 women, over 365,000 women, in need of publicly funded family planning that lack reasonable access to a clinic offering the full range of contraceptive methods. It doesn't mean there's no clinics. In every county in Massachusetts has multiple clinics that offers the full range of methods, but it's about that ratio that I was talking about. So for example, in Berkshire County, which is less populous, the access picture is not that bad. You have 7,610 women in need of publicly funded family planning and 5 clinics offering the full range of contraceptive methods, but it's still not the 1,000 to 1 ratio you're looking for. If you look over at Worcester County, I have family in Worcester County, and I look at that and I see a less than ideal situation. 43,970 women in need of publicly funded family planning care and only 6 clinics, meaning more than 7,000 women per clinic, 7 times what we consider reasonable access. So it's not that the access isn't there, it's that the ratio of people in need to the access that's there is not a reasonable amount. So next slide, please. So we've talked a little bit about what the federal government has done that's harmed some of these programs. And we're talking a little bit about the ways in which the Biden administration can make it better. But states are great innovators. And I will tell you that in almost any policy arena, a lot of the good ideas that ultimately end up in federal legislation start out as state policies. So what are states doing? I like to say that none of these policies alone is a panacea, but taken together, they can really help to ensure that more people have access to all methods of contraception. So some states are looking at what we call extended supply of contraception. So in Massachusetts, pharmacists are required to fill up to 1 year of contraception, one visit. So long as your provider writes it the correct way, they can give you that full year all at once, which helps to eliminate gaps in coverage. I will tell you that policy also exists in DC, and I am constantly having to educate pharmacists about it. So it's not enough to have a good policy. That policy needs to be disseminated and communicated well to the people that are going to have to act on it. So if you find yourself at a pharmacy and the pharmacist says, no, that's not going to work, the insurance won't cover it, just ask them to try it out. Try running it for the full 12 months. Another popular policy at the state level is to codify the contraceptive coverage requirement of the ACA into state law. This policy really took off in the wake of the 2016 election, when I think lots and lots of folks were worried about the future of the Affordable Care Act. And states, particularly states like Massachusetts, were looking to shore up the existing requirements around no copay coverage. Other policies that we've seen, a lot of states are experimenting with having pharmacists prescribe certain methods of hormonal contraception directly. So rather than having to go to a clinic or a doctor's office, you could just go to the pharmacy, have a chat with the pharmacist, and right there they would screen you for any risk factors and prescribe birth control. That policy has been adopted by several states, but I'd say the rollout is going best in the state of Oregon right now. And we just published a little brief about sort of the best practices that folks have learned from how things worked in Oregon. Another thing that should be of interest to folks on this webinar is some states are looking at ways to educate college students about unplanned pregnancy. So this was an idea that took off in Mississippi, where there's a lot of policymaker resistance to comprehensive sexual health education at the high school level. But once folks are 18, some of that opposition neutralizes a little. And so the state of Mississippi was finding that not enough of their older adolescents were graduating college, and that was indirectly having an effect on their economic mobility. They could have the best, most tax-friendly policies for a business, but if they didn't have a skilled workforce, they weren't drawing business to their state. As a result, in a bipartisan way, they invested in a program that provided money to all colleges and universities, including community colleges in the state, to talk about unplanned pregnancy, to provide resources for where contraceptive care could be accessed near those campuses, particularly important for community colleges that often didn't have a health center on campus. So another sort of innovative out-of-the-box idea. The Medicaid family planning expansions that I talked about earlier are another example of the kinds of things that states have done, as well as a really simple solution for a problem that was widespread, which was a lot of times women want a long-acting method of birth control inserted right after delivering a baby. And the way Medicaid covered those services put a barrier up for hospitals in terms of being reimbursed for that IUD or implant being inserted immediately postpartum. So just solving that billing problem helped a lot of people who said, I just had a baby, I'm really happy about it, but I would like to space that next child several years, and I would like a long-acting method. So, and then finally, I will just say that the Affordable Care Act's option to expand Medicaid for all childless adults up to 138% of the federal poverty level was also a game changer when it comes to contraceptive access. Next slide. So here's just a look at sort of how these things have taken off year by year and state by state in terms of proactive contraceptive coverage and access policies. So it is not there's no way that this happens only in blue states. Like I said, Mississippi is a nice example of one of those. Next slide, please. So I want to talk a little bit about one of the tools that I hope you will avail yourself for if you're interested in this topic, which is the Advancing Contraceptive Access Toolkit that we have on the Power to Decide website. You'll see the link there. This is a project we have worked on for about 1.5 years to put together all of the proactive state policies that are out there that states are experimenting with to increase contraceptive access. And actually the latest thing that we just added, it literally went live today, is our telehealth policies, where you can look state by state at telehealth policies in both the Medicaid public insurance space and in the private employer-based and individual market space, and see what are the policies when it comes to covering contraception through telehealth. Next slide, please. So I just want to explain a little about this picture. This is one of my favorite Gary Larson cartoons, and I have enjoyed it throughout my my time working as an advocate in a tough environment for this work. And one of the things I've always said is that we as advocates cannot do this work on our own. We rely on everyone being basically a contraceptive access evangelist in their own world and in their own environments. That includes in the environmental community, it includes with your friends and family. So one of the things I like to talk about is what can you individually do given everything I've just laid out. So one thing you can do is learn about the access issues in your community. Where are the clinics that have the full range of contraceptive methods? How can we increase access? And that map I showed you of our contraceptive deserts is available on our website, and it is interactive. So you can click on a state, and once you're in your state, you can hover over any county and see the data on that county. That map comes from a database that we have of over 14,000 publicly funded clinics, pretty much every part of the publicly funded family planning safety net. Planned Parenthood clinics, Indian Health Service, CDC, state and county health departments, you name it, it's in there. So you can check out what it looks like where you are, where someone you love lives, and really sort of get a picture for what it really means to have good birth control access. The other thing I can say is advocate for greater access to birth control. This is really basic healthcare, and yet routinely it gets singled out, treated differently with special rules instead of the way it should be, which is as a basic essential part of women's healthcare. So use social media. I will throw up all of our hashtags and handles, at the end of this, and suggest that you follow us, and we post about important policies happening at the state and federal level. Contact your federal and state policymakers. I can't stress this enough, that even if you have great lawmakers, and I say this because, both Massachusetts senators, for example, are excellent when it comes to birth control, and Massachusetts delegation is great, but there are many, many priorities that policymakers at the state and federal level have to grapple with. Your state policymakers are going to be grappling with a huge revenue shortfall from people losing their jobs and therefore less tax revenue coming into the state. They're going to have to make hard decisions about how to balance the budget. In the context of that, what are the investments you want them to make? These are really important conversations for policymakers to hear, even if you perceive them as on your side. The more policymakers hear from their constituents about issues, the more they are likely to prioritize those issues. Next slide, please. So the other thing you can do is learn about birth control at an individual level, and then help your friends and family to do the same. So Power to Decide runs a website called bedsider.org. It is basically a one-stop shop for everything you could ever hope to know about birth control. You can click on different methods, watch videos of folks talking about what they like and don't like about their method, the pros and cons. We have a clinic finder where you can find the nearest clinic near you that offers that method. We also have a place where you can search for deliver to your door services that are active in your state in case you want something like the pill or the patch delivered to your door. So it's a great resource and I recommend it to anyone. I jokingly say that with all due respect to my CDC colleagues, this is sort of the opposite of a CDC pamphlet, and a really great resource. Next slide, please. So among the tools that I mentioned is our clinic locator. You can also set birth control reminders. And like I said, look up the nearest birth control method to you. You can also do the compare and contrast methods based on your priorities. Do you want something you don't have to worry about every morning? Do you want something that lasts really long? Do you prefer something that's more short acting that you don't have to stay on for a long time? To search those methods. Next slide, please. The other thing you can do is just in shouting it always surprises me how much this helps, but to just talk about the fact that birth control makes a difference in people's lives, that it helps them achieve this environmental goal of having fewer children than say their parents did. We see people join us every November for our Thanks Birth Control Day and throughout the year using this hashtag. And it's amazing some of the comments we get. The one that always floored me, because I've worked on improving contraceptive coverage for women in the military, was a former Army officer tweeting, "Thanks birth control, because changing a tampon in a sandstorm really sucks." And I just had to pause, because in my civilian world, that's an aspect of birth control and its value that I never would have thought of. But some methods of birth control will help you not get your period for extended amounts of time, which would be a huge help if, say, you were on convoy duty in Iraq. So after I saw that tweet, I contacted some of my friends who served in the Army, and I was like, so what was it like to get birth control? And a whole new piece of our policy work was born. So just an example of all the varied ways in which people find value in being able to plan and choose when and how many children they have. Next slide, please. So before I give you all the information about how to follow our organization, sorry, one more slide. Before I give you more information on how to follow our organization, I'll just say, feel free to follow me. I'm a policy wonk, and you can also shoot questions my way after this if you're not able to get your question answered now. I'm happy to read you resources or answer anything I haven't covered. If you could go to the final slide, please. So please be sure to check us out on social media. That's where you'll find the latest on these policy issues, what we're working on, what is time sensitive in terms of ways that you as an advocate can get involved and contact your policymakers, and a whole lot else. And with that, I'm going to turn it back to the awesome Elena and her awesome team to talk about questions.
Thank you so much, Rachel. So much information in that talk, much appreciated. So I think I will also ask, we have a couple of students who are joining us here to help moderate our Q&A. And so Julie and Najee can feel free to pop back up here. And we can see here if one of them has a question that they would like to pose to Rachel.
I myself don't have any questions, but we can start with one of the Q&A questions.
Please go for it.
The first one here is, do you view any person's choice to have a child currently ethical, especially in the US, given the surplus of children waiting for adoption?
I absolutely do. I will say, as a matter of both my personal belief and that of power to decide, reproductive autonomy is critical. And that includes everyone having the ability to make choices for their own family. I will also say that one of the most heartbreaking conversations I ever had with one of my friends who's Black was surrounding the likelihood of children based on race to be adopted out of the foster care system. So I think that while we think about making sure that everyone has a loving home, and by the way, if you ever think about wanting to be a foster parent, like, consider it. It's incredible. And I know some foster parents personally and could not be more grateful for what they do. But I do think that when it comes to reproductive autonomy. We have to let people make their own decisions for their family. The minute we start saying it is unethical for you, person over here, to have another child, we are imposing societal and systemic views on who should and should not have children. And we have a long and ugly history of that in this country.
Thank you.
Next question asks, at what age are we currently / do you recommend starting education on family planning?
Oh, that's a great question. So the real answer is that it's really a lifelong thing. And there's a lot of resources we have for parents on Power to Decide. And I can shoot a few to you that are also not ours that I think are great and have shared with parents before. But the important thing is that truly comprehensive sexual health education is through the lifespan. So it's everything from using accurate names for body parts with very young children to talking about what is appropriate and inappropriate touching, to teaching young children about respecting other people and not touching somebody if they don't want to be, all the way through to talking about sexual health. So there is no perfect age, but what we often say is it's also not the talk. It is a series of open conversations throughout your child's upbringing, making yourself available to have those conversations. And there's a lot of tips. I have a former boss who used to have these conversations with their teenage sons while they watched a tennis match, because it was easier for the teenage sons not to be embarrassed by the conversation while everybody was just staring straight ahead at a tennis match. So whatever works for you, and your dynamic with your children, that's the way to go. But the other thing I would flag is when we poll young people, and we ask them, who do you want to hear about this the most from? Who do you want to learn this from? Invariably, parents think it's anybody but them. But invariably, almost every young person says that the person they want to hear from most is one or both of their parents. So it's really, really important. And then above and beyond that, adult siblings, coaches, teachers, everybody can be a champion for young people. So one of the things that's happened in my life because of what I do for a living is that sometimes I get asked questions about this. And I'm not a doctor, I'm not a sexual health educator, but I'm happy to field, resources and share things that others have said worked. So I think also educating yourself so that when young people cross your path, you can be that resource for them, because you don't know what other resources they have. Maybe you're adding on to some already great conversations, and maybe you're the first person to talk about it with them.
We have another one here. Does your program support, or are there any widespread movements to push for women to be allowed to get hysterectomies at any time after age 18 without medical reason? Follow up, how can individuals work for this?
It's a really great question. I will tell you that mostly because we are a 3-person policy shop, we don't have the bandwidth to work on that issue specifically, but it's something that we've highlighted and addressed on Bedsider in the context of reproductive autonomy and what's available to folks. I continue to see stories and even anecdotes in my own circle of friends about this. And I really do believe that, and this is a personal view, Power to Decide doesn't work on this issue, as I said, but my personal view as somebody who's done reproductive health advocacy for 20 years is that not trusting women at any point, or people rather, when it comes to their reproductive health decisions, at any decision point, is at best belittling and at worst directly harming their ability to make their own decisions for their families. So I am a 41-year-old woman who does not have children, and that's by choice. And if I had decided that a hysterectomy was the way I wanted to go, I would be appalled by a provider thinking they knew better what I needed for my healthcare than I do. So.
Our next question is, what is the best way to advocate that will have the best effect about birth control?
It's a great question. So it kind of depends who you're advocating with. I sometimes talk about the conversations I have in social circles with folks that are more conservative about it. And it's like a conversation of buts. I have no problem with birth control, but I don't think the federal government should fund it. I have no problem with birth control, but I don't like who, which is often code for Planned Parenthood, provides it. And I think, there are different ways to talk about different pieces of that issue. And we actually have a brief on our website called Everyone Loves Birth Control that sort of goes through, a lot of the things that we commonly hear. Well, why can't you just go to Walmart and buy a pack of pills there? It's cheap. Why can't you just use condoms or not have sex if you don't want to get pregnant? But I think when you talk about the best ways to advocate with policymakers, there's a couple golden rules out there. One, call or email. Do not write a snail mail letter. In the post 9/11 era, it will take your letter 5 weeks to make it to a member of Congress because it has to be irradiated first. And actually those letters start to look a little crispy. So you want your message to be heard quickly, email, and even better, picking up the phone and calling. This goes for state and federal lawmakers. The next thing I'm going to say also applies to any policymaker at any level. Identify yourself as a constituent. That should be the very first thing you say. If I'm writing so I live in DC now, so I do not have representation in federal government other than a delegate. But let's imagine I'm back home in Massachusetts and I'm writing to Senator Markey. The first thing I'm going to say is, hi, my name is Rachel Fay. I'm from Newton, Massachusetts, zip code, whatever. And I want to talk to you about supporting, let's imagine it's increased funding for the Title X family planning program. We know that there are so many women living in contraceptive deserts and that the current supply does not meet the need. And I need you to make sure that the constituents in Massachusetts have the resources they deserve. That's paraphrasing, but essentially you're making sure that they know that your voice is one of the ones that votes for or against them in every election. You are quickly identifying what the issue is, and if possible, giving them state or locally specific data to back up your argument. And that's where some of our contraceptive desert research and other polling can be helpful. The other thing I'll say is it is very early in the legislative session, particularly for the federal government, but as specific opportunities to weigh in come out, Power to Decide has a great feature where we'll send you, basically you'll see us tweet it, we'll send it out through our lists, so sign up for our email lists. And you can literally click on a button and it will give you a sort of template email that you can send directly to your members of Congress. And then you can, tweak the wording however you want, click send, and it's going to go to your House member and both your senators. So we try to make it as easy as possible, knowing that not everybody's job is to be a full-time advocate for reducing unplanned pregnancy.
This next question is, how can individuals help volunteer or intern for the Power to Decide program?
Great question. So a couple of things. For internships, if you go to Power to Decide's website and at the bottom, you'll see work with us. That'll take you to a website. We solicit resumes and applications for interns throughout, but right now I'm not aware of any particular department that's hiring intern at this moment. But basically we hang on to those resumes, and then when there's an internship opening, we go through the ones that fit that department's needs and reach out to those folks. So I definitely recommend doing that, and also following us on social media, LinkedIn, Twitter, Instagram, Facebook. We post when we're hiring. In terms of volunteering, we don't have a formal volunteer program, but there's a few things you can do. One, join us on things like Thanks Birth Control. So use that hashtag THX Birth Control and shout out what it means to you. Follow us for other activities that we ask for folks to do, like contacting their members of Congress or signing a petition to support X or Y. And then finally, on the Bedsider website, we have something called BC Benefits, which is a contraceptive access fund. It helps pay for birth control for those that don't have insurance and don't have another way of paying for birth control. And it also helps to cover uncompensated costs like gas to get to and from the clinic. Remember that in some parts of the country, people are traveling over 100 miles to get to the nearest clinic that has their method. In the future, we hope to roll out reimbursements for things like uncompensated time from work or childcare. The problem is that the fund can only cover as many people as we put money into it. So for $5, you can cover a month's worth of pills for somebody who needs it. And we have a whole bunch of things on the BC benefits, and I'll make sure to get this link to you guys and pop it in the chat. But BC benefits has a lot of different levels that you can give at, from $5 up to way more. And you can tell exactly what you're going to get for that. You're going to give X number of people this amount of birth control and this kind of method. So if you or anyone in your world has the ability to contribute to that, it's a really direct, meaningful way you can help somebody out right now. And if you're in need of it, I would encourage you to check it out.
All right, the next one says, wonderful presentation, thanks. Slightly off topic, but as a society, what can we do to encourage American middle and upper class couples who contribute most to the climate crisis by consuming more and traveling more to have fewer or no children?
So I think, again, when it comes to higher income folks, you are talking about an issue of convincing people, because the data show that that's not where the bulk of unplanned pregnancies in this country happen. So we're talking about planned pregnancies in that space. So I would defer to you all from an environmental standpoint to say, what are the arguments that are compelling? What makes people care about the environment? As somebody who works on birth control, what motivates me to take actions that are geared towards sustainability? And I don't know the answer to that in the environmental space, but I do think that when you're talking about people who use more environmental resources, it's not a matter of lack of access to birth control, and it's not a matter of unplanned pregnancy. So it's got to be, how do you, in their level of hierarchies of what's important, notch up the issue of sustainability? My political gut says it has to do with their children's future, but that's a guess, not a data-driven answer.
This last question here, I personally identify with as a gender neutral person, but has the program worked, or is it working to use more inclusive language to be more gender neutral?
Yes, it is. And you can probably see I policed myself a few times during the presentation to correct it. One of the things we struggle with in this movement is some of the data that we're using is specific to the term women. So a lot of raw data about who uses birth control is not broken down in a gender non-binary way. So sometimes I'm forced to use the word women because, for example, contraceptive deserts, that data comes from census data about the number of women of reproductive age at or below a certain poverty level, layered with clinic access data. So there are times when the movement can't do that. One thing I've seen that I really like, and I've actually had a few initial conversations internally in my office about, is there's a group called the National Health Law Program, NHELP. They're wonderful, and they spend a lot of time suing the government when the government is not doing its job to help Medicaid beneficiaries in the fullest sense, and I adore them. And one thing that they've started doing is saying up front, we will use gender neutral language any place we can, and where we're not, it's because of the nature of the data we're using. And I can't speak, as a non-binary person, but I feel like that's acknowledging it, saying up front that anybody who has the ability to have a pregnancy should be included when we're talking about a policy of planning and spacing pregnancies. So I don't know if that fully answers the question, but I think it is the next level of where this movement in general is going. And there's a lot of us talking about that and working to undo bad habits, frankly, about this stuff.
Well, I would like to thank you again very much. I'd like to thank our student moderators, Julia and Najee. Great job. Appreciate you fielding those questions. And before signing off, I want to invite all of you to come back and join us next week again, when we'll be hearing about cycling for sustainable cities. Rachel, thank you so much. Thanks also to Jackie working in the background to keep all of this running.
Thank you.
I hope that we'll cross paths again. Thank you again.
Thank you so much for having me, and good luck to all of you. It's a fascinating set of topics you guys have chosen. Thank you.
Thanks so much. Good night, everybody.
Bye.